few numbers here. Just give me 1 second to pull them up. Okay, so system-wide, we have tested 811,180 people. Sorry, we've done 811,180 tests. We've tested 459,262 people, and that positivity rate in total is 16.8%. As we've seen, that's been driven up a fair amount by the Delta wave of late. At Baptist Memphis, we've tested 69,748 people with a percent positivity of 10.6%. If we look at the hospitalizations for today, at Baptist Memphis, there are 112 COVID positive people in the hospital in acute care non-ICU beds. There are 38 people positive for COVID in the ICU for a total of 150. 26 of those 38 people are on ventilators. If we look at 79 of our 80 ICU beds are currently occupied, and of the there are fully vaccinated people in the hospital right now would be 10 out of 150 here, and one out of the 19 admissions over the last 24 hours were fully vaccinated. At Baptist DeSoto, there are 86 people in the acute care hospital with COVID-19. There are 17 people in the ICU for they have 3 fully vaccinated people in the hospital, and 0 of the 15 people admitted over the last 24 hours were fully vaccinated. So as you can see, we're trying to keep track of fully vaccinated people, which is a little trickier than you would think because we only have the computerized data on that for people who were vaccinated within the Baptist system. So somebody coming from out of town, other things like that would be hard to know. But of course, we ask them, and we're trying to incorporate that into the data that we give. But there may be some degree of error in that, but I think it's largely accurate. So happy to answer any questions if you have any.
Hey, Dr. Threlkeld, it's Corinne. How are you?
I'm okay, Corinne. How are you doing?
I'm doing all right. So I wanted to ask you about a potential decline in vaccine efficacy. There seems to be some indication, among frontline workers that vaccine efficacy has declined, and there's also some evidence coming out of Israel, which obviously we've talked about again, has a stellar vaccination rate, but they're starting to see more and more breakthrough cases.
Yeah, exactly right. And that's really, I guess, the reason a lot, really, the Israeli data and others for the bit of change of course in the government plan to give boosters at all. And, it's important to point out that you're supposed to change course based on the data that you get. That's what science does. It can be key how you portray those issues, though, and how you explain it to people, because it can seem as though you're doubling back and you're contradicting yourself, when really what happened was, for the longest time, there was really no indication that there were a lot of breakthrough cases that were important clinically. Yes, there were some cases where people were positive, and the data you're talking about, I think, at least a part of it, showed that in some frontline workers and healthcare workers, the efficacy of preventing infections at all dropped from 91% to about 66%. And there's some important caveats about that. In some ways, it's more accurate because they based it on weekly testing, and that can be helpful. But some of the problem would be that when they're changing over the course of that experiment, Delta came to town, and so the numbers rose significantly of cases during that time. And when you look at the percent error, or the range of results that could have been accurate, it's a pretty broad range. It ranges in from the 26 to 84% in the efficacy once COVID was involved. So there are some limitations in that test in the results. But I think it's pretty clear that the vaccine and immunity in general has suffered some decrease because of the Delta variant. The Delta variant is a lot more contagious. Obviously, it's caused a lot more problems. The question is, how much of our natural immunity has waned as well, allowing for those breakthrough cases? And this goes into the question of the booster as well. So when you find that that we're having more cases, it just means that our immunity is farther away from where that virus is now than what it was before. And in the same analogy, if you and I are far apart, it may be that you moved away from me, or maybe that I moved away from you. We know that Delta has moved away from us in a significant way. We know that the mutations involved there make it more contagious, but it also bears out some resistance to our immunity, both natural immunity, even more than vaccine immunity, but to vaccine immunity as well. And so we've seen for a while now that cases of breakthroughs have increased. We saw that really on the ground before it was well documented nationally, in that we just had a lot more cases of people who were vaccinated coming to the hospital than we saw before. Not a lot, but more than we had before. There really weren't any when you really pull back before the Delta variant. But what's important is, even with this drop in efficacy that study showed, it does not show a significant drop in the efficacy against severe infection and death. So the vaccine is still excellent against that. And of course, we sometimes forget that really is job one for a vaccine. And the fact that it's still even 2/3 effective against preventing infections at all is all by itself still an important thing, remembering that we were going to settle for 50% way back in the beginning. So the problem is, does this mean that we need a booster, I think? And so are we moving away from the virus just like the virus is moving away from us by mutations? It turns out, like you see in a lot of relationships, it probably is the case that both parties are moving a bit away from each other. The virus clearly has mutated away from us, but it seems more and more that our immunity is beginning to wane. We've seen it a bit more clearly in the data from Israel and other people that were kind of ahead of us in vaccinating a large proportion of their populations. So a little more in the way of infections and a little more in the way of more serious infections is creeping in to their data set than what we have seen here. So I don't think this is an emergency in the United States, but it has made the CDC and FDA and others begin to change their thought about whether or not a vaccine booster is going to be helpful in the very near future. And of course, the administration has decided that later next month, there will be a campaign for that to begin. So it's not clear completely how much of the increase in cases is just because of Delta and how much of it is from our loss of immunity. Some loss of immunity over time is natural. When we measure things like antibody levels, it may or may not be accurate. And that's something we have to caution against. Too many people are going to their doctors and having antibody levels drawn. They say, well, I'm going to wait until the antibody level drops to X or Y value before I bother getting my vaccine at all, if I've had the infection before, or if I've had one vaccine before I get my second one. And that's not a good idea, because we really don't have good correlation with what that means. We don't have what we call correlates of immunity. There's not a value of antibody that we can say, aha, you're protected by that. Some of those challenge studies in the UK may address some of that if we get those data back anytime soon about exactly what antibody levels seem to protect people. But we don't know that yet. So it's important not to rely on antibody levels to decide whether you need, whether it be a booster or if you need your original vaccine at all. So to sum up, I think, yes, it is I think been plain to us sitting here on the ground from the beginning, and it certainly seems to bear out in the studies that we're getting back now, that there is some resistance with the Delta variant compared to the previous variants to both our natural immunity and to the vaccine-induced immunity. It's just that the vaccine immunity is still quite a bit better. It's excellent against severe infections. If you look at the CDC study recently that came out of Kentucky that compared people who had the natural infection versus people who had the natural infection and then got a vaccine on top of it, there was a 2.3-fold protection for the people who got the vaccine on top of the natural infection. So it becomes, I think, one of the most difficult things that I'm facing right now. People keep asking, well, I've had the real infection, so I probably don't need the vaccine, don't you think? And I think the data would not suggest that the vaccine would still add to that natural immunity that you got from the real infection.
Hi, Dr. Threlkeld. It's Kelly with Channel 5.
Hi, Kelly. How are you?
Hey, good. Thank you. I wanted to get your take on the vaccine in those waiting for an organ transplant, and possibly those who are a transplant recipient. I've been reading different studies just showing what the efficacy looks like within those patients. Are they getting the immunity that others are getting? I mean, are these the people that need to be first in line for the booster shot? What's the right thing for these types of patients to choose when it comes to the vaccine?
Yeah, it's a very good question, because the solid organ transplant patients are really at the core of some of the actual numbers that were gathered. And that really was how the whole question came of a third shot for immunosuppressed people, were some studies from Johns Hopkins, particularly on solid organ transplant patients. There were also some studies in the UK for people getting chemotherapy, and they actually had a better response to the vaccine, probably than solid organ transplant people, heart, lung, kidney, and the like. So it turns out that if you get a vaccine before the transplant, that's great. We always try to give people as many vaccinations as they're going to need before they get an organ transplantation. That is routine for those of us who work in transplant. We have a heart transplant program that we provide here. So we try to get people's vaccines in. Now, if you have a live vaccine, like the measles, mumps, rubella, those kind of things, you don't want to take that right before you get a transplant and get heavily immunosuppressed. You want to get those in about a month before. But anytime you can get a vaccine like the COVID vaccine in before you are immunosuppressed with the organ transplant, you want to do that. It just gives you extra protection. The immune system has plenty of time, 2, 3, 4 weeks, to generate good immunity now and some of those memory cells that can recognize the problem later a bit more effectively. You can just generate more of them when you do that. Now, after transplant, there is some discussion about how soon after a transplant that you get a vaccine. It sort of depends on how much immunosuppression you get. Sometimes we use particular types of antibodies that really pound the immune system initially, so that there's less chance of rejecting that organ. But once a few weeks go by, we certainly recommend that everybody get the vaccine. This infection has been particularly brutal for solid organ transplant patients. They've done poorly with them relative to other patients. But to your point, we found in those data that I mentioned from Johns Hopkins and other sources now that they don't do a great job of responding to the vaccine. That's not a surprise. We still recommend it because the response rate is 0 if you don't get it. If you look at the folks who did get the vaccine after solid organ transplant, or anybody after a solid organ transplantation, about a lower percentage of the folks generated antibodies. And when they did, they tended to be lower. Now, did a booster or third dose of the vaccine help that? And it did, sort of. It took about a third of the people and increased their antibody levels, between a third and a half, depending on the group that you're looking at. And for those who developed some antibodies and were still kind of low, but really had not some antibodies, it boosted almost all of those, though the numbers were relatively low that they looked at. So I think everybody pretty much would agree now that this is an entirely different question from should everybody get a booster. There's a lot more discussion about that than there is about this. People who are immunosuppressed and who didn't get a decent response after the first two, that third hit of a vaccine can actually make a difference and give them better immunity. So we essentially suggest it for all of our solid organ transplant patients. And one other spinoff of that problem, though, is that if you get infected despite your vaccination, or if you didn't get one, if you get COVID-19 and you're an immunosuppressed person, then you should be the person to go get the monoclonal antibody therapy for 2 reasons. Number one, because this population of patients is just so hard hit by the infection, you have a much higher chance of getting severe illness or death. And secondly, you have a lower chance, as we've been talking about, of developing an adequate protection response to that vaccine. So the monoclonal antibody can temporarily boost up your immunity and your antibody levels to help ward off the actual virus. And for 90 days or so provides you that umbrella that helps you get through that infection. So not only are these population of people the ones that, yes, should get the booster, and they should get it now. It's already been suggested for that. But we should also be very careful to talk to your transplant coordinators or your doctor about getting the monoclonal antibody if you come down with the infection, even if you've been vaccinated. I'm not as excited about everyone who's been vaccinated getting the monoclonal antibody therapy. We do give it to some, but we really stress it for people that got the vaccine but have any number of immune compromising conditions. And that's not just organ transplant. That can be people who are taking prednisone or other steroids for autoimmune diseases, other kinds of cancers with chemotherapy like leukemias and lymphomas. There's several populations of folks that would be at risk for not having a good response to the vaccination, and therefore they would be good candidates to get the monoclonal antibody. Any other questions? I have a couple from the feed. Stephanie McLeod asked, so the vaccine really works? Is that why we now need to get a third jab? I'm not sure the total thrust of that question, but it really works in that I can walk through my ICU and only one person in the ICU that I happen to be rounding on today with 12 or 13 patients is in that ICU having been vaccinated. So it is true that we do get breakthroughs, but they are very uncommon. They tend to be in elderly folks and folks who have otherwise not had the greatest response to that vaccine. And those numbers continue to bear out, even with this concern of some resistance to the vaccine. So yeah, I think it really works fantastically in that sort of sense. And then the third shot, as we mentioned here earlier, may be just a matter of boosting that up for a longer period of time. It compensates for some of those changes that the Delta variant and others might be making to get around our immunity. And it also adds significantly to the protection that you get from your own natural infection, particularly if you got one before the Delta variant. Now, if you got a Delta variant just in the last few weeks, you may very well have a regional immunity for some time, like we talked about way back before we saw variants. But that's only until the Gamma variant or one of the other variants comes to town and then sort of takes over, and then you might not have good immunity at all. Ronnie Blankenship asked, how do they know what vaccines really work on the new variants? Which vaccine? So good question. What they typically do, and one of the easy ways to do it is take the blood of people who have had the vaccines, the various vaccines, and they check their blood to see how well that blood in the test tube inhibits the virus. In other words, what kind of antibodies they have that might knock out that virus. So you can tell that if everybody vaccinated does a great job of inhibiting or neutralizing the Lambda variant, let's say, then you know that that vaccine seems to work well. We may find that people who have had the natural infection don't do as good a job with their blood in a test tube inhibiting that virus. That's one of the ways that they preliminarily look at those things, even before they have a chance to do clinical studies to see how many, of course, people end up getting those new variants. That's kind of the ultimate test of it, but that takes a while, obviously, to do, and we want to avoid those cases if at all possible. Anthony Huffman asked several times, in fact, you're talking about the mask. Can the virus pass through the mask? By the way, Anthony, I can't see the question as you're asking it, so I have to kind of wait until after to the next time to actually answer the question. So the question again, can a virus pass through the mask? And this is one of those controversial things that's engendered a whole lot of discussion, and the mask data can be tough to wade through at times. But I think the idea that most people that ask that question are asking is, aren't viral particles small enough to make it through some of those particulate masks, particularly the cloth masks, or get around them? And that very much is true. They are that small. But the thing about it is, those virus particles don't hang out by themselves. They quickly dry out. You can't really do that. Viruses tend to travel in respiratory droplets. That's the real question. It's not how big is the virus. It's how big is the cab the virus is driving in. Where does that go? And masks are pretty decent at blocking those. 100%? Of course not. But it also is particularly important for the person with the infection wearing the mask. Once again, if you cough or sneeze and you have COVID-19, you are not ejecting viruses out. You're ejecting droplets of respiratory secretions that carry that virus. So that's the thing that you have to stop. And by and large, masks do a pretty decent job of that if you are sneezing or coughing into that mask and not just right at somebody across from you. It's most effective, of course, we find when both parties are wearing masks. That's why it's important in hospitals for both the patient and the nurse or the doctor taking care of them to have that mask on. It's also that way in your bridge club or your basketball game crowd. It helps for both, certainly in the classroom, we talk about a lot now. And you say, well, how can you tell? Well, you can't, and that's the whole point. So when you can't tell who has it and who doesn't, the important thing is for everybody possible in a school classroom to have the mask on and to be reasonably separated. That's how you prevent transmission much more effectively. Terry Novell asks, so you shouldn't take steroids or antibiotics for this? I think that refers to the point I made last time. That was one of the mistakes that I see being made a lot. Steroids are sometimes necessary if you're a bad asthmatic. There are times when you have to take steroids for a number of reasons. There are times when you need antibiotics for a lot of reasons. But if you just have an outpatient case of COVID-19 at home and your oxygen is okay, you're not needing to go to the hospital or very sick, steroids and antibiotics are in general not the right thing. So you probably don't need antibiotics for any viral infection. Now, if there's some chance that you have some other bacterial process and your doctor or nurse practitioner thinks that you do, there may be exceptions to that, but by and large, they're not helpful. And further, steroids, prednisone pack or a Medrol dose pack, they can be important in some situations in certain asthmatics that are having flares. But in general, somebody taking steroids for symptomatic relief for COVID-19 is the one thing you do not want to do. Nasal steroids would be a little more controversial. The data aren't as clear on that. But if you look up at the National Institutes of Health guidelines or anyone else, they'll point out that the study showed that steroids like dexamethasone are life-saving once you need oxygen and you are ill and in the hospital. However, there was a trend toward increased hospitalization and death in people in the trials who took steroids before that point. Now, why is that? And just briefly, early on in the stage of the infection, the virus is taking on our immune system and it's a race to the finish line. We'd like the finish line to be getting well. The virus wants otherwise. And so it makes copies of itself as much as it can, and our immune system tries to stop that. And it turns out that if it makes a lot of viral load, it can sort of overwhelm our immune system and make us reasonably sick. And so if you take steroids, you will help out the virus in that race to get a head start and make more copies of itself. It seems that when the virus has a really high viral load in you, that it has a little more likelihood of getting the immune system caught up in trying to play catch up and doing maladaptive things like damaging your lungs and shooting the gun off in your own house rather than at the virus. And so when that sort of thing happens, then you need the steroids to calm down the immune system that has become kind of maladaptive and overactive, if you will, and damages our cells. So early on, you don't want the steroids. So if someone gives you a prednisone dose pack or Medrol dose pack, just because you have COVID and are at home and okay with normal oxygen, which you should monitor, you should ask very carefully, why do I need the steroid? If you're a bad asthmatic or there's some other reason, there are reasons to take steroids, but by and large, they are not necessary in the average person with early COVID-19. It's a very important point. I see a lot of people getting them, and it does potentially cause a problem in those situations. So we want to avoid those in most situations where they're not obviously absolutely necessary. Diane Werkheiser asks, so what happened to the seasonal flu? Nothing really happened to it. It's been around. It's been so incredibly rare because we've been engaging in all of those behaviors that prevent flu transmission. It turns out that COVID-19, the Delta variant particularly, is a lot more transmissible than the flu. It's more up there almost with chickenpox and the like, and the flu is just not. We think of the flu as very contagious, and it is, but this is a new beast that we're kind of battling here with even more contagion than the flu. So the things that we did to ward off COVID-19 when we were being careful about it really knocked out the flu tremendously. And it goes to show you it's not just Tamiflu that fixes the flu. It's avoiding the thing altogether. And we did a pretty good job of that over the last year. I expect to see as we relax things, the flu will almost certainly return when we see that. Angela Gordon asked, what about taking zinc and vitamin C? And we mentioned that briefly before. They are fine to take. They probably cause no harm. But it's important to point out, if you look at the studies, there is no real study that shows benefit of those. If you take it and you feel better, fine. But if you look at hundreds of people who are studied against people who didn't take it, it really made no difference. Zinc, in fact, can cause a little nausea. It works against the rhinoviruses that cause the common cold, but in order to really get the benefit from the respiratory infection, people had to take enough to make themselves nauseated. So choose your poison on that. There's no evidence that it helps, but it's fine to take in at least reasonable doses, likely. Anthony Huffman again asked, does wearing a mask weaken your immune system? Of course not. Your immune system is what it is. You're sort of born with it. The idea that you stimulate your immune system is not really much of a true issue. You you can dampen its function a bit. Obviously, you can take steroids, as we mentioned. You can even have a little bit of a downward turn from not getting enough rest and exercise and the like. But these are small kind of maneuvers. I suppose you can say that if you're a small child and you've never been exposed to anything in your life, you might get more common colds as an adult than you did as a child. When I moved back to Memphis to practice medicine, I got some colds that I hadn't been around. And when I had a kid, we've all experienced this. Parents get some colds when their kids are in nurseries, and so you might be exposed to more stuff. But there's no evidence at all that wearing a mask affects your immune system. Your immune system is an innate army of cells that recognize two things: you and not you. And anything that comes in you that's not you, a coronavirus, an organ transplant, any of the like, the immune system gets very distressed by that. And whether you're wearing a mask or not really doesn't have anything to do with that at all. Christy Barkley asks, home COVID test was positive, but the health department rapid test was negative. How accurate are the home tests? Terrific question, one that I'm getting a whole lot now. We sort of had it for a while and that question went away. But we have to realize an important thing about these tests. They are very specific, even the home test, and certainly the PCR test or even the rapid test. They're very specific, but they're not terribly sensitive, which means you might miss them a lot, but if it's positive, it's almost always positive. And I see way too many people getting a test that's positive, and they say, I don't believe that, I'm going to go get another one, and the second one is negative, and then they go to work the next day. Infecting people. So the analogy I always give, and I apologize, I've probably given it before, is the wildlife camera. If you buy a nice wildlife camera and point it out in the woods somewhere and take 20 pictures overnight, and you come back the next day and you see one picture with a deer on it and 19 pictures without a deer, my question is, are there deer in the woods or not? And the answer is yes. So you say, well, what about those 19 pictures that didn't show a deer? And then you go out and buy a nicer camera, and the next night you see 10 pictures without a deer. It doesn't matter. In wildlife cameras like coronavirus tests, a positive test is much more important and convincing and true than is a negative test. So the positive predictive value, to throw another epidemiologic term out there, if you have a test that's positive, without the most extraordinary problem, we have to believe that that's the case. There's no need to repeat it because 2 or 3 negatives against 1 positive do not stack up. Are there ever false positives? Yes, but they frequently involve an entire tray of a test run being contaminated. And the lab can usually tell that very easily because they'll have all of a sudden 50 positives. And that's not going to be the case. They can usually tell that at the time it happens and rerun those tests and remove the contamination. So a very important point, do not doubt positive tests, particularly at this point. Just a couple more. Anthony Huffman again, what happened to letting your immune system do what it's supposed to do? We do hopefully let the immune system do what it's supposed to do, but that does not include being exposed unnecessarily to chickenpox or measles or coronavirus. So the immune system is supposed to rid those things. It just so happens that in letting the immune system do what it's supposed to do, it's supposed to fix viral infections, but over 600,000 people have died of COVID in the United States alone. So sometimes it's not good enough. And if you play a high school basketball team, you'll look really good. If you play the Grizzlies, you'll be just as good the next night, but you won't look as good. So it all depends on the opponent you are playing. And right now we are playing a very bad opponent that we don't want our immune system to just try its best. We want success, and the vaccine clearly has provided that for us in a lot of ways. Christy Garrison asks, you only get 1 flu shot, so why are there more for COVID? Actually, we get a flu shot every year. And so I think I'm not sure, I may not be understanding the question correctly, but, and it's the reason why we need a vaccine on top of our natural immunity from the Wuhan variant or the Alpha variant. People say, well, I had the infection already, and so I don't need a vaccine. And it's about like saying I had the flu last year, so I don't need this year's flu shot. But it's not the same flu anymore, so you're not going to get adequate protection. The same thing is true between the Wuhan original variant and the Delta variant.
Dr. Threlkeld?
Yes.
I'm sorry, we had one question from ABC 24, Rick, and you may have partially addressed this question. He wanted to know if you could comment on the vaccine efficacy study about the falling to 66%. Do you have local evidence that mirrors that research, and are you concerned that the findings might work against our vaccination efforts?
Oh, that last part is particularly a good question. So yeah, I think that So our numbers locally are pretty good, and they really are in terms of the vaccine. And remember again that there's a large variability in that result, and so it had a wide range of error there. So it's not really a black and white result in the sense that we know it really is 66%. As I mentioned, the range of variation dropped down to about 30 and up into the 80s. So I would say, just have a number in front of me, we have 586 patients right now in the entire Baptist system, and 5% of those people are vaccinated. And it's certainly been the experience that we have had, and I continue to have. It's hard to tell exactly how many people are getting asymptomatic infection and getting infection and therefore having breakthroughs, but we certainly can tell you that those breakthroughs that are occurring are by and large unimportant in terms of their risk of hospitalization and death to that person. The reason that they are still important, and the reason in part that the national authorities are thinking about giving vaccine boosters, is that there are some people who can get sick, certainly, and that may be creeping up ever so slightly in other countries who are looking at the people who are vaccinated the longest time ago in the elderly population. They'd be most at risk for getting sicker, and also they had the earliest vaccines. So it's important to knock down infections per se, and vaccinations do. The immunity from vaccines definitely cut down by several-fold infections at all, but not completely. And if a booster can increase our ability to prevent that virus from spreading to other people who might get sicker, suppressed people, elderly, and the like, then that can be important. But certainly the vaccination still is doing a great job of protecting you against severe illness. And so that's really always been the most important job. The booster may increase that a bit, and it also will likely more impressively improve your ability to ward off the infection altogether and not to give it to other people. So a very good question. And just one or two others here. Janice Sawyer asked, what are your thoughts about children getting the vaccine? I think that it's very important in the school-age kids. The one thing that I would be concerned about is that people are going out and trying to get vaccines for their kids under 12. And that's kind of the opposite problem from what we're used to addressing. Most people were trying to say, please get your vaccine if you're approved to get it. But I would also say, please don't try to bend the system to get the vaccine for your 10-year-old, even if they're sort of large for being 10. And try to get your pediatrician or somebody else to sort of bend the rules and give that vaccine. The reason I would say that is that we have to be consistent with what we do. We have to wait for data. The data on the safety and efficacy for the vaccine in people under 12 are just not back. And we would be hypocritical to say, well, we want to wait for data. We want to do what the data show. But if we really feel strongly about it or particularly emotional about it, then we should not wait for that stuff. That's the whole point of what science is doing, is trying to prove to within a shadow of doubt with statistical relative certainty that what we're doing is the right thing. And did some of us give hydroxychloroquine early on in this campaign? Yeah, a lot of us did for a very short time when we just didn't have any data. And there were very preliminary data that suggested that it might be helpful, and although it wasn't very strong, and people were just dying around it. And taking care of patients in medicine. And so, yeah, we've done some things that weren't particularly scientific or statistically sound, but the more we go, the more we have data to answer these questions. So I think it's just a bad idea to push ahead and actually do that on kids for which the data really aren't back yet. So any other questions I can answer? Okay, thanks guys, have a great weekend.
Thank you.